Mr. Rakesh, make Ojas Poddar a co-host. He's answering. And make Mr. Abhishek Ghost co-host. He's also answering.
Hello.
Hello, good evening, sir.
Good evening,
Good
sir.
evening.
Good evening, sir.
चालू करें?
Good evening. Good evening, everybody.
हाँ सर, गुड इवनिंग.
Good
चालू
evening,
करें क्या?
Good evening, sir. Yes, sir.
Just throw up, Ganesh, just 4 to 5 minutes.
ओके, वो 9:30 को डॉक्टर पलक विल जॉइन अस.
No problem.
मतलब शी विल टेक हर लेक्चर पर आफ्टर
No
9:30.
problem.
मतलब एट 9:30.
Yes.
मैंने उसको 9:30 बोला.
Yes, let her join at that time.
हाँ. तो वो जैसे ज्वाइन करते हैं, देन वी कैन टेक अ ब्रेक इन द अदर थिंग सर.
Yes, we'll take the break.
ओके.
Mana mukala. No, nothing. Ganesh. Ganesh.
Ganesh sir is logged out, sir. Well, he is not online.
He is logged out.
No, he is still logged in, but he has left the screen for some time. I think.
Achha. So I think he must be after 1 or 2 minutes.
Yes, sir.
Dr. Gite has joined.
Not yet, sir.
Achha, I'm just trying.
Okay.
So as soon as he joined, in 1 or 2 minutes, we just start. We start in 1 minute. Huh?
Sir.
Who is answering today?
Sir,
what-
Pooja's here, sir.
Yes.
Yes, sir.
Abhishek
Doctor-
here, sir.
Dr. Abhishek and Dr. Ojas. Last time.
Oh.
Last time.
Fine.
Dr. Ojas, can you please switch on your video?
Yes, sir.
Thanks.
Good evening, sir. This is Dr. Kamal from Atlee Hospital, sir. Sir, regarding last case, sir, I had one question. If we have 1 minute, I can ask.
Tell me, what is that?
So last time we were discussing regarding vesicovaginal fistula.
Yeah.
Sir, I just had a small question regarding, is it mandatory to check bladder leak test after closing the bladder, after the repair?
Yeah. It is, that is what we are doing it. It is a
Sir,
different books have mentioned differently. That is for when are you doing per vaginal? I told you, Shomu Raj usually does that. So that is
Yes,
a
sir.
practice.
Okay, sir. Sir, my concern was that if we checking the leak test, and is it little dangerous if I overextend the bladder and my suture can
No. Only 200 cc.
200 cc.
Yeah.
See, not only that, but whenever you suture the bladder, otherwise also for nephroureterectomy with a cuff of bladder, or if you are doing a Bovary's and suturing of the bladder, or anything where you're suturing the bladder, it is always best to put 200 to 50 cc and check the bladder.
Okay.
Yeah.
And preferably, sir, gravity method rather than forcefully pushing, gravity method, how much the bladder can accommodate.
There are two methods. One is that if you can you have a sterile Foley and you attach a saline bottle directly with gravity. Another thing is, we know how much is the capacity of our this thing.
Bladder.
Bladder.
Yeah, I mean bladder wash ka asepto. So
Asepto.
it's usually 50 to 60 ml. So you do
Exactly.
it 3 times at least. It gives you 180 ml.
Yes, sir.
I mean, that's not rocket science to calculate
Slowly
the
you just
capacity.
fill up. Gently you fill up. Okay.
Yeah.
Ganesh, I think we should start now. Fine.
Sir. No problem.
Okay. And Ganesh, whatever
sir.
it is there, but the history is also little important. So if you find anything, then
ले
please,
लेते हैं history. Sure, sure.
history. Right? Okay. Achin, please
sir.
go ahead.
A Hindu gentleman, 47 years of age, resident of Mumbai, veterinary doctor by profession, came with chief complaints of left flank pain since 3 months. Should I start? Should I go on?
Yeah.
Let's
So
start.
this is the history. Hello. Abhishek.
Yes, sir.
Ojas,
Yes, sir.
Yes, sir.
So,
quick.
sir, with this history, sir, it is a short history of 3 months with left flank pain. This could be a pain associated with stone disease, sir. This could be some pain associated with some inflammatory or infective pathology, sir. And I would like to proceed with the history accordingly, sir. First, I would like to characterize the pain, sir. What is the onset, duration, and the progress of the pain? Is it radiating, non-radiating, sir? The character of the pain, sir. Any aggravating or relieving factors? Is it relieved by medications or change of position, or the patient has to go to the hospital to take medications for the pain to come down? Is it related with micturition, sir? And other than that, sir, for infective pathology, sir, I would like to elicit history of any fever associated with the pain, sir. Yes, sir, any fever, any dysuria associated, any lower urinary tract symptoms associated with the pains. And yes, sir, and in stones, sir, any history of passing of stones, sir, that will, any infective history, sir, any history of hematuria, sir, hematuria, fever, dysuria, lower urinary tract symptoms associated with pain, sir. That was I'd like to proceed, sir, with the history.
Okay. Dr. Gite, now as an examiner, I am just asking you because when the adrenal mass is there, in such cases, normally whenever there is a pain in the left flank, I mean any flank pain, we are not asking any history about adrenal. So what is your say in this case?
Agreed, sir. He should have started with elaboration of pain only and negative history of the probable causes of left loin pain, right loin pain. So probable causes is either any diureter or any cystic. वैसा ही करना है. In between, अगर कहीं clue मिल गया तो then he has to ask the history about the adrenal disease. Majority of the adrenals are nowadays is incidentally detected. So don't think with only pain. If he asks everything about adrenal, then the examiner will see that the student is knowing the diagnosis. That's all.
Okay. Ganesh, you want to add anything from your point of view?
ठीक है.
Like in Tata, will you have any specific history or something?
नहीं sir.
Okay. Okay. Achin.
If we are discussing adrenal targeted, then we will go ahead with history of various diseases of adrenal. Otherwise, whatever the Abhishek has asked and told is correct.
Okay. So, just you want to add anything, or we go ahead?
So any history of trauma in the past and any altered bowel habits, any history of constipation, any history of passage of blood in stools.
Okay.
So what you are expecting, suspecting by asking the blood in the stool?
So I would for asking regarding blood in the stools, I want to find out if the current complaint is related to any GI tract related. So I want to rule out any anything in the descending colon or in the small bowel. That could also have pain in the left flank regions.
Okay. 10-20% people will say to your answer, this is the exam of urology. Why someone will keep the patient of gastroenterology, patient having problem of gastroenterology, the exam of urology. But theoretically, your answer is accepted.
Yes, sir.
Okay.
Sir. Yes. Patient was apparently asymptomatic 3 months back when he started developing left loin pain, insidious in onset, gradually progressive, dull aching type, continuous in nature, non-radiating, relieved by medication, aggravated by moving around, and there is no positional variation.
Okay, fine. Go ahead with the negative history also.
No issue of nausea, vomiting, no issue of fever, burning, micturition, no issue of any lithoria or hematuria, no issue of trauma, no issue of any previous similar complaints, no issue of facial puffiness, lower limb edema, exertional dyspnea, no issue of altered bowel movements, no issue of blood in stools, nothing like that.
Pain aggravated.
By mo-
Aggravated by moving around is a sign of pain due to infection, no?
Yes, sir. But he gave this history.
Yeah. So read.
So sir, exam में थोड़ा manipulate करना चाहिए क्या ऐसा?
I think so. Minor manipulation is always acceptable, na? Dr.
चलो, ठीक
Gite?
है.
Sir,
Let's go ahead.
with this chip complaint, he should target the inflammatory, malignant, and obstructed. तीनों को नेगेटिव हिस्ट्री पूछना चाहिए. अभी एड्रेनल का
बराबर.
क्वेश्चन आता ही नहीं है.
आता ही नहीं है. And if you ask more about adrenal, examiner बोलेगा कि तुम्हें केस पता है.
हाँ,
Correct.
तो अननेसेसरी पकड़ा जाएगा.
Fine. So yes. So unless and until in these cases, if the patient says he has got a headache or he has got some other positive history, then you can always go ahead with that. Otherwise, just routinely go ahead with the main chief complaint as a kidney. Correct?
Yes, sir.
Yes, sir.
Okay. Achin, go ahead.
Sir, past history, there is no issue of any diabetes mellitus, hypertension, ischemic heart disease, history of tonsillectomy at 13 years of age, family history, nothing is contributory, diet is mixed, appetite adequate, bowel bladder is regular, sleep is undisturbed, and patient is non-smoker, non-tobacco chewer, and non-alcoholic.
Fine. Ojas, anything
sir.
else you want to ask? So now we know we are not thinking in terms of adrenal when such a history is there. Okay.
Yes, sir. Yes, sir.
So you should not show that you know the case. So you go as if it is only the kidney problem.
Yes, sir.
Mainly.
So, sir.
First of all, just 1 minute. Pankaj has joined, and just to everyone's information, he has become this thing. Treasurer-elect of Urology Society of India.
Congratulations.
Yeah.
Congratulations, sir.
Thank you very much, everyone.
Yeah.
It's all because of your.
Congratulations, sir.
Thank you.
Yeah. Okay. Fine. Go ahead.
Sir, general examination.
As history is going on, we will finish it up the various types of presentation of adrenal diseases. Otherwise, वो फिर रह जाएगा.
बराबर. Adrenal के कुछ conditions में क्या history रहता है? Like if there is a PO, what will be the history?
Yes.
Sir, in case of PO, it is usually a young female, sir, who complains of hypertension and headache, palpitation, sweating, hypertension which is not treatable, which is intractable, which is not treated by medication, sir. And yes, sir, also history of weight loss may be associated, sir.
Okay. Any MEN2 syndromes वगैरह?
Yes, sir. In family history, sir, we have to elicit history of MEN2 syndromes. Sir.
Yeah. So if you want to complete FIO, you should go on everything like that because that's theory.
Yes, sir.
Okay. Next.
Yes, sir.
There can be functional other adrenal problems, right?
Yes, sir.
Functional means secretions from the GFR.
Yes, sir.
Bolo.
So just so that they can be from the glomerular, that is the aldosterone producing tumors can present as Conn syndrome. Then we have from the fascicular layer that is secreting glucocorticoids, that is cortisol secreting, that is Cushing's syndrome. And then we can have those which secrete from the reticularis, that is adrenal sex steroids. And from the medulla, we have either the pheochromocytomas or the paraganglia.
So you're right, but about the medulla, we discussed the history.
Yes, sir.
about
So-
the outer three layers. Sex steroids means there will be enhanced or depends on the secondary sexual characters.
Yes, sir.
Okay.
Yes, sir.
About the Cushing syndrome, then you will have to have a brief, 2, 3, 4
Yes,
sentences on Cushing's.
Yes, sir. Proximal muscle
Correct.
weakness,
Muscle
abdominal
weakness,
fat deposition, abdominal
Correct.
striae, easy bruisability, and
Correct.
yes,
Hello,
sir. Yes. Increased weight, loss of libido.
Right.
Those things, sir.
So
osteoporosis.
that is what Gite
Osteoporosis.
sir was asking you.
Yes, sir. Then,
And-
sir, for cons, we will ask cons is technically, sir, hypokalemia, so muscle weakness, sir, nausea, vomiting, any lethargy, any history of polydipsia, sir. Although non-specific, but sir, can be associated with cons, sir.
Right.
And then, sir, moving on to sir, Addison's disease. Sir, Addison's disease we are associated with generalized fatigue, so generalized loss of muscle weakness, generalized loss of appetite, nausea, vomiting, weight loss, myalgia, sir, and other than that, sir, yes, sir, hyperpigmentation. Yes, sir, Addison's disease. Yes, sir. So that is.
Then,
And
so adrenal malignancies like adrenal cortical carcinoma will either be functional or it can be associated with a larger mass having a flank pain and associated symptoms regarding the invasion. Then we can have incidental findings done like incidentaloma which is discovered on a cross-sectional imaging with done for any seemingly unrelated causes. Then we can have adrenal angiomyolipomas, which can again present as a large mass with flank pain.
Okay.
Yeah.
And adrenal metastasis from a other malignancy could also be one of the presentation for adrenal
In
disease.
adrenal, correct.
And adrenal cyst, yes sir. Adrenal cyst also could present as a large mass with flank pain.
Okay. We go ahead, sir. हो गया बस.
Yeah,
सर
only
ऐसे
thing is
ऐसे ही यूजुअली डिवाइड करना पड़ता है कि द सिम्टम्स ड्यू टू इंक्रीज इन कॉर्टिसोल, सिम्टम्स ड्यू टू इंक्रीज इन अल्डोस्टेरोन, सिम्टम्स ड्यू टू इपिनेफ्रिन, symptoms due to dopamine. Then examiner may ask you what are the signs and symptoms of acute attack of the fever, and what is by hypertension crisis. Then what are the rule of 10%. What are the 5 P's of pheochromocytoma. ये सब routinely asked questions है एग्जाम, तो ये आना चाहिए.
Yes sir.
ये एमएस के क्वेश्चन है, क्योंकि आड्रिनल का आया कि ये सब चीजें पूछेंगे. 10% एक्स्ट्रा आड्रिनल, 10% चिल्ड्रन, 10% familial, 10% bilateral, 10% multiple, ऐसा 10% recurrent, 10% malignant, ये 10% टिप ऑफ टंग पे रहना. 5 P's का है तो प्रेशर इंक्रीज 9%, पेन है, परस्पिरेशन, पाल्पिटेशन, PLR, पैरोक्सिज्म, ये सब चीजें पता रहना चाहिए. फैमिलियल के टाइप्स अगेन मेन टू ए है, मेन टू बी, VHL, NF1, ट्यूबरस क्लोरोसिस, एक हर उसमें और क्या क्या आता है वो तो पता रहना चाहिए.
Yes sir.
तो उसको कोई अल्टरनेटिव नहीं, क्योंकि एड्रिनल का केस बहुत कम रखते हैं, लेकिन अगर रखे तो ये चीजें पूछेंगे.
Okay, sir.
ओके, वी विल गो अहेड.
Achin.
General examination, sir. Patient is conscious, cooperative, well oriented to time, place, and person, well built and nourished. Pulse is 80 beats per minute in right radial artery. Regular rhythm, good volume. BP is 110 by 80 mm of Hg in right arm supine position. Respiratory rate is 20 cycles per minute. Afebrile patient. Respiratory is 98% on air. BMI 22. Karnofsky score is 100. No evidence of any pylorictatus sinuses, clubbing, lymphadenopathy, edema, and head to toe and spine examination is grossly normal.
So, anything in particular either of you want to know?
Sir, blood pressure in particular, sir, but that is normal, sir, in this.
Yes sir. Pulse and blood pressure is normal and pulse is regular, so that in particular.
Yes, sir.
No, that is normal, sir.
So now suppose if you are looking after adrenal mass, okay, or adrenal problem, then anything specific you want to know? From the history only, if you have come to know that there is adrenal case, and in that case, anything specific you want to know?
Sir, in history, I would like to find out about family history, sir, other than the history that has been already
No,
told.
no, just now you people have talked, na? So that is what I am asking you. Is the syndrome, anything related to syndrome or anything related to, once you know that it is a adrenal case from the history,
Yes,
then
sir.
in examination, what are the positive things you are looking for?
So, sir, in general examination, we will look for stigmata of parathyroid adenomas, sir, and any history. Yes, sir, parathyroid enlargement we would like to see, sir. And other than that, sir, general examination of genitalia will also want to do, sir, in suspected case of adrenal, sir. Yes, sir.
So for
You
functional
already
tumors in Cushing's, I will look for in general examination central obesity, buffalo hump, easy bruising and striae. Then in if any sex steroid secreting tumors, I will look for signs of viralization. Then in those associated syndromes, that is neurofibromatosis type 1, type 2, we'll look for any neurofibromas or any capillate spots over the body.
Yeah, so these are the important things. So just
Yes.
keep it in mind. Anything, Ganesh, anything else you think they should look after when they are 100% sure that this is a case of adrenal mass?
सर वो difficult है मतलब adrenal case can be a small adrenal मतलब relatively smaller adrenal mass or say 7 centimeter adenoma also, so it is difficult to have symptoms always.
Fine.
Means
Okay.
after some deliberation in history, we will have to finally leave it and go to the evaluation.
Okay. Pankaj, you want to add anything?
No, sir.
Fine. Okay. Achin, go ahead.
So local examination per abdomen, patient examined in supine position with implied informed consent with exposure from nipple to knee in adequate room light. Inspection umbilical centrally placed, all quadrants moving equally with respiration, no scar, sinuses, engorged veins. Palpation, there is no localized of temperature, no tenderness, bladder not palpable. Percussion, tympanic not present all over the abdomen. Normal liver dullness span, auscultation, normal bowels on nothing positive, sir.
So in case, Ojas, if
Yes,
you
sir.
are looking forward for an adrenal mass, so what you will find out? Maximum.
Say we can have a loin mass on inspection. We can have a loin mass, mass and irregularly defined or a well-defined mass in the flank region.
Is it possible?
So in large masses, it might be possible.
So, Ganesh, how big the mass you can palpate normally if the adrenal mass?
Sir, even if it is 7-8 centimeters, we usually are not able to palpate.
Exactly.
Okay, sir.
So that is what I
Because
want to
adrenal is not
understand.
going to be palpated like a bimanual or a palpable palpation.
Yes, sir.
It is not possible. Adrenal has a very unique niche position where tremendously big it can be palpated, but 8-10 centimeters is also usually not palpable.
And if it is a functioning, then if you do palpation, then there are chances of palpitation, right, Ganesh?
Yes, sir. Yes, sir.
Sir, yeah. So if it is functional, then things can happen.
Yeah.
Agreed.
Anything else you get? Because you are coming across such cases so often, Ganesh.
Nahin,
Anything
sir,
positive?
because many nowadays are come on one extreme of incidentalomas. The other extreme comes when usually, very honestly, there is some vague pain in the abdomen. People do sonography or a CT scan and detect an adrenal mass which may be 6-7 centimeters.
Huh.
Some are referral patients which come from, say, usually from gynac. A slightly more incidence of adenomas in the females probably.
Okay. Fine. Okay, Achin, go ahead.
Sir, respiratory system is normal, CVS is normal, CNS is normal, sir. Then investigations.
So, just before we
Yes.
go ahead, just what are the positive things you may get? again the same thing like in examination, you said general examination. So in CNS, RS or CVS, will you get any positive thing if it is a functional mass or adrenal tumor?
So in CVS, we can have, sir, tachycardia or any abnormal auscultation sounds if there are associated arrhythmias. In CNS, if it is associated with this thing, neurofibromatosis or Men's syndrome, then we can have neurofibromatosis, then we can have neurological manifestations. In Cushing's, we can have depression, insomnia, and but
No.
no, yes, sir.
CNS examination.
Examination.
Maybe the proximal muscle
Sir,
weakness.
muscle weakness, sir, muscle atrophy may be there, sir, in case of Cushing syndrome, sir. Other than, sir, on general physical examination, sir, BMI, central obesity, sir, all other stigmata, including moon face, buffalo hump, increased pigmentation of the skin, sir, and sir, muscle atrophy, sir, in CNS examination, sir, thinning of skin can be seen in Cushing syndrome, sir, and sir, the pubic hair, sir, virilization of female genitalia, sir, can be seen, sir. And other than that, sir, in other systemic examinations, sir, we can
So
find.
you are talking of a systemic. Don't talk of general. Someone is saying tremors, then murmurs. You know, these are the specific things. Just 4-5 things which are important. In general examination, you have already talked about what you will see on screen, what you will see other things. So here, very specific about whether you see anything in respiratory system, CNS, or in CVS, any 2 or 3 points. So that only we wanted. So okay, fine. So just remember and make points. So only once in a while you may get such cases, but you should be aware. Fine, let's go ahead.
Investigation, should I start?
Yeah, so now next what? Abhishek, what do
Sir,
you do
this,
now?
yes, sir. Sir, this patient only has he's a middle-aged gentleman, only has complaints of pain since 3 months, sir. I would want to do some routine
So
investigation.
what is your differential diagnosis? Very simple. Just tell me 3 or 4 diagnoses which are coming in your mind.
Left flank pain, sir. Stone disease is coming in my mind, sir. First of all, sir. Second, any infective pathology, sir. Thirdly, sir. Yes, sir. I'd stick to these two, sir, as
Sir,
per the history.
So left flank pain, I'll give a differential of stone disease of the kidney or of the upper of the ureter. There could be a PUG obstruction, 3 months history. PUG obstruction could be one case. The inflammatory causes pyelonephritis. Then it could be cystic disease of the kidney.
Fine. So these are the main things otherwise that is a big list. Correct?
Yes,
but
sir.
otherwise, normally we are saying that these are the 4 or 5 differential diagnoses, and the last is a malignancy.
Yeah, renal malignancy, I suppose.
Yeah, renal malignancy. So these
I
are
don't
the,
think we can pinpoint to adrenal in any possible way, and let us keep it like that.
Yeah, so we are talking only of the kidney. So these are the 5 differential diagnoses. So keeping this in mind, what are the investigations you will ask for?
Investigations, sir, routine investigations with emphasis on total leukocyte count, sir. Then, sir, urine routine and urine microscopy, serum creatinine to be done, sir. And other than that, urine routine microscopy and urine culture and sensitivity, sir. And along with an ultrasound of the KUB region, sir.
Okay. Achit, go ahead.
Yes, sir. Investigation shows hemoglobin 15.2 and count is 4,700. Serum creatinine is 1 and electrolytes are normal. This is the ultrasound picture.
Yeah. Can you comment? Any one of you?
Right kidney appears normal. Kidney cystic lesion.
Who's reading?
Abhishek,
Sir,
you
on the
want to?
ultrasound, sir, kidneys
एक
are
किडनी कम दिखती है क्या?
liver is visible, sir. Kidney is visible.
Right.
Only
Both
one
the
kidney is
kidney, left
visible.
kidney, right kidney.
Right kidney.
Can you see something in the first left hand side first?
I can't make out, sir.
Can't make out,
This
sir.
is right kidney with liver, no?
Yeah.
पता नहीं ऐसा लग रहा है.
नहीं ऊपर फर्स्ट में लेफ्ट में.
And there is gallbladder.
अच्छा, that Aparna has joined, then we can just ask her and then she can continue.
No, Palak is going to join. Palak.
अच्छा, Palak is going to join. So Palak has joined.
No. She'll join, but anyway, sir, अपन थोड़ा सा imaging कर लेते हैं तो it will be benefit when she takes a lecture.
Okay, no problem. Fine. Okay, so if we are not able to see it very clearly, can you read it, Achin?
हाँ sir. Sonography is essentially normal, sir. Both kidneys are normal in size, having smooth renal margin and normal renal parenchyma. No evidence of valvular hydronephrosis. Right kidney and left kidney have normal sizes. There is no mention of adrenal mass in the sonography report. Only GB polyp is there.
Fine. So how to go about that? Abhishek.
Sir, would do a contrast enhanced CT scan of the abdomen and pelvis, sir.
Why for?
Sir, to find out the cause of the pain, sir, left flank pain. Would be because of
Ultrasound is normal. Ultrasound doesn't give any clues to the GU problem.
yes.
So
sir.
now what are the possibility? What are the causes of pain in the left flank? What else comes in your mind?
Sir, non-neurological causes of pain, sir.
Yeah, tell us. Just 1, 2, 3.
Normally, what you will do, you will give analgesic and refer this patient to general surgery to rule out the general surgical point. Normally, that's what all people will do, including me. Until
Correct.
and otherwise, there is some clue. Why you
Yes,
will
sir.
do a CT scan?
Yes, sir.
I mean, इसमें तो कुछ भी नहीं है जो urologist continue करे. And gallbladder polyps लिखा है in the end.
Polyp भी दिखा है उसने gallbladder का.
Patient will first go for a cholecystectomy, then come for re-evaluation.
True, sir.
Correct.
So I think we should proceed because otherwise their गाड़ी अटक जाएगी, sir.
हाँ, this sir.
There should be some indication. I think the sonologist, it is slightly difficult to see the adrenal directly. But clever sonologist should, I guess, try to fathom there is something with respect.
Sonography has shown. Let us say that
diagnosis. A sonologist should.
sonography has shown that there is
Sir, मैं क्या बोल
some
रहा था? Sonologist should either say that it is abnormal upper pole.
Fine. Abhishek, how will you go about?
Sir, then I would like to do a contrast and CT scan of the kidney and the urinary bladder region. And can we please?
Okay, this is the CT scan.
उसमें non contrast करेंगे कि नहीं?
Sir, upper polar lesion अगर दिख रहा है sir sonography में, then we should proceed with the contrast enhanced CT scan, sir, to characterize the lesion, sir.
लिपिड रिच है, लिपिड नॉन रिच है, कैसा पता चलेगा अगर adrenal
Yes,
मास?
sir. CT में पता चलेगा.
तो adrenal का प्रोटोकॉल ही है ना, उसमें नॉन कॉन्ट्रास्ट भी करना है, डिलेड फेज 15 मिनट का भी करना है, कॉन्ट्रास्ट भी करना है.
Yes, sir.
तो मिस नहीं करना है.
Okay.
डायरेक्टली अगर कॉन्ट्रास्ट का नॉन कॉन्ट्रास्ट नहीं किया, ऐसा कैसे हो सकता?
Right.
Okay, read this.
This is a contrast enhanced CT. But this is a pre. Okay, this here. Contrast enhanced CT scan of the abdomen plus pelvis. The lower basal, basal lobes of the lungs appear normal. Liver is normal. Spleen is normal. Right kidney appears normal. Left kidney. Right kidney shows good excretion of. No, but I can't see the delayed images. Yes, ma'am. Left kidney.
I have other images also actually.
Yes. Can we see the other images?
Angiography images also there.
Okay.
Okay. Sir, in the given images, sir, the left adrenal appears enlarged. Enlarged.
Near the spleen.
It is abutting the spleen with the dimensions of 31 by 40 mm. It is showing. Not. It is showing a non-enhancing pattern with the small with small areas of small hypo enhancing areas seen, sir, in the middle of the lesion, sir.
Where? Just show me.
Sir, in the center, sir. In the
Okay,
in the
yeah, couple of just enlarge.
Oh, sir.
Achin, can you just zoom in?
Yes.
sir, right here, sir, in the center.
Yeah, two areas are seen, and in the here also. Yeah. Okay.
Yes, sir. So most likely this could be adrenal cyst or adrenal hemorrhage, or it can also be a fat poor adenoma, sir.
Okay.
Yes, sir.
Fine. So in this case, what will happen? Now, next what? Just report. Just Chin.
Sir, a lobulated, well-defined soft tissue density lesion measuring 4.2 into 3 centimeters seen replacing the left adrenal gland. Lesion shows central hypodense area with a tiny speck of calcification along its medial margin. On post-contrast study, the region shows an absolute washout of 92%, the relative washout 39%, with perilesional fat planes appearing maintained. Consisted with a moderate size indeterminate lesion of left adrenal gland.
Okay.
So
it has a good washout. So
good. Yes, sir. It has a good washout.
92% absolute washout and 39% relative washout. So it could be more likely be a adenoma.
Fat, more in the direction of cyst or hemorrhage, or it can be in a fat poor adenoma, sir.
So next, what will do now? What will do now? You want
sir,
to do anything?
Sir, we want to carry out the hormonal characterization of the lesion, sir. Do blood investigations and urine investigations to characterize the hormonal profile of the lesion, sir. We do a salivary cortisol as 24-hour salivary cortisol assay to rule out Cushing, sir, do urinary fractionated catecholamines and metanephrines to rule out pheochromocytoma component, sir. Serum electrolytes we would like to do, although in this case it is normal, sir. And other than that,
So how will you go about? You will do everything together, or you will do very systematic?
So we will do 24-hour urinary metanephrines and urinary or serum cortisol levels, and if the electrolytes are normal. So here I want to do aldosterone levels, and there are no any other signs suggestive of hypersecretion of mineralocorticoids. So I will do this first 2 tests and then go ahead, sir.
most,
Ganesh,
yes, sir, most,
See, 24
how-
hours urinary catecholamine levels now nobody does. We do serum plasmaphrine or metanephrine.
Metanephrines, yes.
And secondly, the blood pressure is, if the blood pressure is normal, I missed that point. Matlab, if the blood pressure of the patient is normal, then those renin levels and aldosterone is slightly not needed. Serum cortisol is done.
Cortisol is done, yes, sir.
If these 2-3 basic things are going to be normal, there are no altered secondary sexual characters, then we don't do the other tests actually. Then we'll have to go and find, actually go with this CT scan, which does suggest adenoma probably clearly. There is a 92% absolute washout. It's 60% absolute washout or 40% relative washout, right?
Yes, sir.
yes,
Yes, sir.
It's either, it's or basically. So it gets clearly washout, and washout means adenoma. If there is no washout, then you go for the other lesions,
Yes.
or even the other type of adenoma is the fat poor or something. But this is like clearly, right now at least, it is clearly facing us, the diagnosis. So question is now, what will you do with such a kind of patient? Will you like to evaluate more? Will you like to observe? Will you like to go ahead with the treatment? Gaurang sir, I think Palak has also joined. Should we ask her to?
Yes. Then I think better let her finish.
Because we
and
are
then
at the
go ahead.
level of imaging only. So let us finish this topic properly.
Yes.
I think she will have to be made a host or something, na, for sharing.
Yeah, Mr. Rakesh Yadav, please make Dr. Palak co-host.
Or she is joining. So I think I'll just have a word with her. एक minute.
Yes.
So I think till then, let's keep on discussing.
Yeah, go ahead.
So what is the role of MRI? So let's ask this question first.
Sir, MRI will help us to further characterize the lesions, sir. There's very specific findings on MRI for adrenal lesions, sir. T2, sir, if there is a enhancement in T2 weighted lesions, sir, then it is indicative of a pheochromocytoma, sir, on MRI. And other than that, yes, sir.
So if we say, like in some, prostate MRI is better for local staging than the CT scan, right?
Yes, sir.
So how about that comment in adrenal?
So indeterminate lesions on CT scan can be better differentiated in MRI. Then we want to look for if there is a large adrenal mass to invasion of the left adrenal vein or relation with the IVC and the surrounding structures, for any tumor thrombus in the veins to characterize that. MRI would be better. And if any contrast allergy for CT scan, and
then you can use an MRI. But I guess CT scan may be still the #1 investigation in adrenal. I guess so.
It is the gold standard investigation for adrenal.
We have, I think Dr. Palak has already joined us. And Dr. Palak, we welcome you. You joined? Participant shows, no?
Yes. Yes, I've just joined.
Okay.
Good evening.
So Dr. Palak is professor in radiology now at Tata Memorial Hospital, and she is an immensely good radiologist. And thanks to you for joining us at such a short notice. You will, I think, we are rightly discussing the same imaging in this case of adrenal. So till she's sharing screen, अपना एक slide पीछे लेना Achin. Just go through our images from the
Yes.
sonography onwards. So this was our case actually. इसमें sonography में we have probably limited images. So go ahead.
Okay, so there's a left adrenal gland lesion, heterogenously enhancing. Okay.
So we were discussing that, and the last image, वो कुछ तो reconstruction वगैरह.
Yes. Okay.
So this is our case. So I think you can share screen and
I'll stop sharing when you can share screen.
yeah, please.
Okay. Should I share my screen?
Yeah, please.
Okay. So I'm actually, pardon me, but I've got a new system, a new device. So I'm using Zoom on it for the first time, and it is not allowing me to share my screen. I think I need to change some settings. So would you all want to continue until I can sort this out?
Yeah, yeah.
Sure. We'll do that.
Yeah, no problem.
Yeah, sure.
So when you are ready, Palak, just let us know.
Sure, sir. I'll let you know. I'm using, the system is still being set up, and this is my first Zoom on the new device. I'm not able to give it access for sharing somehow.
Yeah, what you can do is you can log out and rejoin. I mean, this happened with me today morning only on a new Mac.
Yes, that's where I'm struggling. Okay. So, I mean, since you're there, can you just tell me what I need to do, or I'll just rejoin? Is that enough, or do I need to change my settings also?
Those things I said, but later on I just left the meeting and then rejoined and it happened.
Okay, I'll just try that right away. Thank you.
Okay. So Achin, let's continue. Sorry.
Yes, sir, no problem.
So what more investigations you want to do, or we are enough with it? Would we like to do a MRI? Would we like to do a PET scan, or should we do a biopsy?
So if the hormonal evaluation is normal and the CT scan showing washout, so it is more likely lipid poor adenoma. So, and if, depending on the functionality, depending on the blood levels and the urinary levels, we will discuss treatment options with the patient. So no further imaging would be required for this.
Okay. Okay with that answer. What is the role of biopsy in adrenal lesions?
So role of biopsy in adrenal lesions is unresectable metastatic adrenal malignancies, in which if you are planning a systemic therapy or if you are planning an ablative therapy, then there is a role of biopsy, sir.
And if you suspect adrenal tumor as a secondary from
Secondary,
of some
yes, sir.
other primary,
Yes, sir. Renal
okay,
cell
suppose there
carcinoma
is
and skin
lung,
malignancies
whatever,
and
it is
lung
treated
cancer.
or whatever.
Yes, sir.
Correct. So another vague lesion is usually when there is technically some lymph node groups with lateral adrenal biopsy, anything else, there can be a lymphoma.
Yes, sir.
Yes, sir.
So role of PET scan in adrenal.
Sir, role of PET scan, sir, specific PET scan can be done for adrenal lesions, sir, especially pheochromocyte. A dotatate scan is done, sir. 68 gallium dotatate scan can be done, sir. And
Either FDG is commonly done.
FDGs are
what you
commonly,
Can be
yes, sir, for metabolically active lesion to find out whether the lesion is metabolically active or not. FDG PET can be done, sir. It is done for pheochromocytoma or other metabolically active adrenal lesions which have equivocal CT findings, sir. So on the basis of that, we can proceed with the hormonal characterization of the lesion.
Okay. And DOTAs?
So dotatate scan, I only read about it, sir. Never
So it
seen,
can
sir.
also be done in pheo.
Yes, sir.
So and paragangliomas.
Yes, sir.
Yes, sir.
Yes, sir. Two localized
So
paragangliomas.
sometimes, I mean, paragangliomas. Okay. So I think because somatostatin receptor SRI imaging they call na somatostatin receptor imaging has a high sensitivity in
Yes, sir.
primary assessment for both PC as well as PGL.
Okay.
So some people like say ki if there are hereditary syndromes or suspected, then maybe you can do a SRI imaging.
Right, sir.
That much only I would tell you. So we go ahead, matlab the treatment part. How will you plan treatment? इसमें और कुछ किया है अचिन?
हाँ सर, वो लैब
show
वैल्यूज
them.
कराए और पेट स्कैन किए सर.
हाँ, लैब वैल्यूज बताया नहीं, बता, सॉरी.
मेटानेफ्रिन इज 46, नॉरमेटानेफ्रिन
तो
72.
नॉर्मल है.
हाँ, नॉर्मल. डिहाइड्रोएपिनेड्रेस्टेरोन इज 119.
हाइड्रोएपिएंड्रोस्टेरोन
मार्जिनली
वो
हाई.
भी नॉर्मल है, दिखता नहीं है, नॉर्मल है.
हाँ सर, मतलब मार्जिनली हाई सर.
ओके.
DHEAS is little high.
ओके.
Then sir, aldosterone is 6.72, normal only. Cortisol is 1.1, that's normal.
Other than that, specific things seen will be electrolytes, na? Potassium and sodium.
Potassium is normal sir, in previous slides I've told.
Okay.
And
So अभी कुछ बाकी है?
chromogranin.
Chromogranin. Okay,
Patient got it by
chromogranin is
himself.
also, serum chromogranin levels are also done in PGLs and PC.
Okay.
Yes.
So now it is marginally raised. So what is the inference?
I will have to check honestly, but kitna significance आता है just for a marginally raised, I really don't know. If you want, as we talk or as the Dr. Palak's presentation goes, I'll check.
Yeah. Whatever. And then even DHEAS was marginally raised.
Or somebody from our team can check and put it on the chat. Right.
Yeah.
So technically they are not indicated because it looks like all the things are normal on examination. So we technically many times rely on that.
Okay.
So
The PET scan has been done.
okay, so we discussed about PET scan. You tell us the finding.
PET scan shows FDG uptake noted in 4.2 into 2.2 centimeter soft tissue lesion involving left adrenal gland. Lesion shows central hypodense area with speck of calcification along its margin. Perilesional fat planes appears clear.
Hello. Yes,
Ganesh, your network is unstable. Yes. And DOTA talk scan also was done, sir.
Okay.
It shows heterogeneal mass lesion in left suprarenal region, does not show somatostatin receptor expression, hence is it unlikely to be pheochromocytoma. That's
Okay.
Fine. So Palak has joined.
Yes, I have joined. Am I audible?
Yes.
Yeah,
So I
to
think
check my screen.
again he will have to stop
sir.
sharing.
Yes, I have stopped, sir. Yes.
Yeah, we can see your screen.
Okay, thank you.
So shall I congratulate you on using the new device and successfully getting it?
Yeah, I had to change the system preference in settings.
Yeah.
Glad I managed.
I always like to hear your talk, and every time I'm fascinated. So please go ahead.
But this time, sir planned it very late.
No, many thanks for your kind words, everyone. So yeah, I'll just take you quickly through like roller coaster ride for adrenal imaging. Okay. So you know the anatomy. I would skip this. All right. So the vascular supply, we have 3 arteries and we have a vein. Okay. So I mean, like we have the inferior phrenic artery, superiorly aorta.
Dr. Palak, sorry, you can go through your presentation. Totally. No problem.
You can go through your presentation. We have no problem.
Yeah, and you all can teach me as and when you all deem so.
No, it's okay.
That's for me to learn.
See, Palak, for you, it may be very important. So you can start from the beginning. Don't think that we know everything or we know anatomy. Please, you can go ahead. Yeah.
Sure. Okay. So, so we know why this is called the adrenal gland. All right. Now it has a very characteristic shape. Okay. So it has a V and a Y kind of a shape, and they are sitting atop. They're like the caps sitting for the kidneys. Okay. And so we generally identify. So when I just partially joined, I heard that the best way to identify, or the gold standard, as somebody said, was a CT scan, and that's precisely because of the amount of fat around it. So when we look at various structures, CT is a very good modality to show you very frank fat. So it's like the whole neighboring is dark and the gland stands out. So that's the beauty of imaging it well on a CT scan. So coming to the vascular supply, okay, we have the left adrenal and the right adrenal. This is the aorta and the IVC, and you have the arterial branches coming here, the superior, middle, and the inferior, from the renal, from the phrenic, and from the aorta, and on the opposite side also. And we have a single vein, adrenal vein, which is seen draining into the adrenal gland. And when we see an adrenal tumor, we actually do see a distended adrenal vein also. And we can actually course the venous supply also very beautifully. And where it matters is because we need to kind of identify if sometimes we can also see tumor thrombus. So we are so used to seeing a renal arterial thrombus or a venous thrombus and a tumor extending into the renal vein. We have also seen that with an adrenal vein. So it is important for us radiologically, or for you all as a physician, asking to probably look for any thrombosis extending in case of a malignancy. So this is how a cross-sectional anatomy would be. This is just a pictorial animation. We have the vertebral body on the left side, the left kidney, and sitting here atop is the adrenal gland. So it's supero-antero-medial. Okay, so they are both pointing towards the midline, and they're both tilted towards the midline. This is on the left. And we have the aorta and the diaphragmatic crus over here, and this is the one on the right. Okay, it is just behind the IVC. On the right side, it is flanked by the liver over here, and all this would otherwise be fat and black on a CT scan, which is why we can actually delineate an adrenal gland very well. So this is how the normal gland looks like on a CT scan. We have the vertebral body. This is the aorta. This is the IVC, and this is the diaphragmatic crus going on either side. This is a section of the liver. This would rather be the stomach, I presume. And this is a part of the kidney. And this is one part of the adrenal gland on the left. And this is the gland entirely seen on the right. So it has a pyramidal shape, and it lies in like a crease between the liver and the diaphragmatic crus. The left adrenal gland is again superior. It is seen over here. It has a relatively more crescentic shape, and sometimes, these glands, like even over here, sometimes there's so much fat, or the anatomy is such that the glands, literally the limbs of the gland, look like as if they are doing yoga. They are like really stretched. Why is this important? Because sometimes you can see a part of, if the adrenal limbs can be stretched out widely, you might miss to see a normal, a nodule or something sitting on one side of it, because you're just so used to seeing a CT scan. This is the kidney, this is the adrenal. You saw that nothing was there. So if even I at this time also would report a CT scan on a very fast note, I can miss an adrenal lesion. So the point going here is, you need to look at the adrenal every single time and trace its limbs in its entirety to catch that lesion. So an eyeballing technique can perhaps make you miss a lesion. This is how the lesion looks on the coronal plane. Again, a nice VY structure. Now, the normal adrenal demonstrates uniform enhancement on the CT scan, and we cannot distinguish the cortex from the medulla. Now, incidentally, you happen to detect an adrenal lesion when you were imaging for something else. So what's the outcome of most of these lesions? A whole lot of times these are benign and these are adenomas. And these are common. They are seen in about 1 to 5% of all abdominal CT scans. What is the role of imaging here? We have to overview the adrenal disease and their imaging appearance. So current the concept is to differentiate a benign from malignant adrenal mass. You look at a CT and an MRI, and there is an imaging algorithm that we follow. We have various modalities for imaging. That is an ultrasound, a CT scan, an MRI, and a nuclear medicine imaging. A routine CT protocol would consist of NCCT, which is a non-contrast CT, okay, or a plain scan of the abdomen, a contrast enhanced CT at 70 seconds delay. This is usually like a late arterial early venous kind of a phase, or a portovenous phase, and a delayed scan, which is after 15 minutes. Now, if you as a physician who is referring a patient does not write an adrenal protocol, what happens in the radiology department is the patient comes, the patient gets a plain scan, patient has come for some imaging and gets a venous scan, and the patient is taken out. So that's where the importance comes, that we need a radiologist to be sitting, to be stationed at the console while the scan is happening. Because you would want to pick up, if you pick up a lesion in the adrenal, which is incidentally picked up, we can choose to take a 15-minute scan then and there at that time with that same contrast that has been instilled. So it also means that if you are sending a patient, if you know there is a history of a probable benign adenoma or a nodule or a metastasis, it's an indeterminate finding. You need to write an adrenal protocol. Let's say there was a JR1 sitting in the radiology department, and the JR1 did not know what is an adrenal protocol or something and missed out. So better to write a delayed scan at 15 minutes. So even if there is no radiologist at the console, even a technician who's going to read the scan will know, okay, I have to scan the patient at 15 minutes for the adrenal. So your job is done. Then we are not then waiting and scratching our heads at why did we not give contrast to this patient. So the imaging modality of choice, as discussed, would be a CT scan over here. MRI, we have certain sequences. We have a standard sequence and certain optional sequence. So these standard sequences are T1, T2 axial, CSI, that's a chemical shift imaging, which I will show you, and a FAT-SAT axial scan. And optional sequences, we may choose to do a post-contrast enhancement and diffusion. The modality of choice for further characterization of adrenal lesions is an MRI. So no matter what I show you, or no matter what I say that, oh, it is so beautifully seen on MRI, MRI is not the imaging method of choice. If we are suspecting, the way to go about is to see a CT scan. A CT scan is going to answer your questions in 90% of the cases. If we cannot identify, it is only then that we resort to an MRI. Again, an MRI is not for benign, malignant, better enhancement or something. No, it is reserved to look at the fat component of an adenoma, which is not seen on a CT scan. So the normal gland of the adrenal on the MR will look like this. So if you have to identify, which sequence would this be, so the best way to look at is the CSF fluid. It is quite dark over here, so this will be a T1 weighted image. You would say that there is some fluid here or something bright here. It could be a paramagnetic substance, it could be some bowel fluid, it could be an oral contrast administered, but the CSF is always going to follow your true undisturbed fluid signal intensity. Okay, so that is the best clue. If I would have only looked at this, I would have called this as a T2 weighted image, but T2 is fluid bright, T1 is fluid dark. So I see a dark fluid in the CSF space, so this has got to be a T1 weighted image. So this is the adrenal gland here. Now let us this is the coronal image. So I do not see the CSF over here. So now I will rely on this little fluid collection seen here in the kidney. So fluid is bright on a T2 weighted image. I could be wrong. If this is a large hemorrhagic cyst on a T1 sequence, it will also look bright. But by and large, not all examiners are nasty. So we presume that they are all going to show us decent, sensible images. So let us presume that this is a simpler cyst, and this is how it looks on a T1. So essentially, it generally follows the signal intensity of your adjoining organs. Now, nuclear medicine, we have PET scans, MIBG scans, and octreotide scans. So we've seen the normal anatomy and how they appear on a CT and an MRI. What about ultrasound? So antenatal ultrasound and neonatal ultrasound, we can actually see the adrenal glands, but in adults, we do not see the normal adrenal gland. Coming to the masses, so there it could be neoplasm or some other masses. So the neoplasms that are seen in the cortex would be adenoma and carcinoma. From the medullary side arising would be pheochromocytoma, neuroblastoma, ganglioneuroma. Stromal would be lipoma, myelolipoma, and metastasis. Other mass lesions can be granulomas, bilateral hyperplasias, cysts, or hematomas. Coming to adrenal diseases, so we have three groups. With normal function or hyperfunction or insufficiency. So looking at normal functional lesions, most of these are incidentally detected as adrenal masses. They include non-functional adrenal adenoma or carcinoma, metastasis, lymphoma, myelolipoma, or an adrenal cyst. Incidentally discovered adrenal masses, again, would be common incidental discoveries on CT, MRI, PET-CT. It is defined as lesions less than 4 centimeters or smaller, can be unilateral or bilateral. Whenever an adrenal incidentaloma is discovered, there are two main concerns, whether it is hormonally active or inactive. Second is if it is going to be benign or malignant. So there are various causes of adrenal incidentalomas, which could be tumors like adenoma, nodular hypoplasia, ACCs, pheos, myelolipoma, lipoma, cysts, pseudocysts, hematoma, infectious granulomas, and metastasis. So we need to know, is this functional or not? So 6 to 20% of these will have a hormonal abnormality, and hypersecretion is most likely if the masses are at least 3 centimeters in diameter. Below 3 centimeters, usually by and large, they may be hypofunctional. So 85% of the masses are non-functioning, 9% secrete sufficient cortisol to produce subclinical Cushing syndrome. We have certain pheochromocytomas and aldosterenomas. So how do we characterize them, whether it is benign or malignant? Now the common site for both benign adenomas and metastatic disease is adrenals. Even though it is a common site for METs, 70% of adrenal masses in cancer patients are benign. So why is this important? Because whenever I am going to see a chest abdo-pelvis and I see an adrenal mass, the first thing that I see is the history. Is the patient a case of a CL lung? Then my antenna go up that, well, most probably this discrete adrenal nodule should be a metastatic nodule. So that's using my logic, okay? But if it is not a CL lung and say it is some other malignancy, I would think, I would think whether is this really a metastatic nodule or not, because then there is a greater chance of it being an adenoma rather than being a metastatic nodule. Trust me, lung carcinoma will also have adrenal adenomas. So you have to get your algorithms right. And how does it start? It starts by looking at the plain scan, which I will come to. So it is essential in determining treatment and prognosis. If it is benign, no further up and metastases, you need to further manage the patient. So I will look at the lesion morphology, the difference in perfusion, intracellular lipid concentration of mass, and the metabolic activity. So what are the indicators suggesting malignancy? As we said, more than 3 centimeters, they are usually functional. If the mass is more than 4 centimeters in size, it tends to be metastatic or primary adrenocortical carcinoma. Irregular shape, heterogeneous appearance, growth of an adrenal mass over time. So stability is very important. CT is undoubtedly the mainstay, but with widespread use of CT, there also has been an increase in the detection of incidentally seen masses. So it's like a double-edged sword. You use it to diagnose and it comes and lights up on your face that, okay, now what do I do? So the two main criteria is to see the intracellular lipid content, which represents an anatomic difference, and the vascular enhancement pattern, which represents a physiologic difference. So what am I talking about? So there is an intracellular lipid content. So within the cell, there is a fat content. All right. This represents an anatomic difference. So what do you mean by an anatomic difference? Because the anatomy, there is an anatomical plane, there is a cell that we're talking of, and there is fat within that cell. So the presence of fat is going to give a certain, reflect a certain density. When I talk of Hounsfield density or HU in a CT scan, what are we talking of? We're talking of the grayness of an image. So in a CT, you see various shades, right from black to white with numerous shades of gray. So the density or the grading of each shade of gray is represented by the Hounsfield unit, which is from a negative to a positive. So when I look at a black fat over here, this is going to be negative. When I look at the air over here, it is going to be highly negative. When I look at the soft tissue here, this is somewhere around 9 or 10 Hounsfield units, which is very low. If I look at a soft tissue like the kidney or the spleen, this will be around 40. If I look at calcium, this is very high. It is about 1000. So this is the way you analyze the Hounsfield units. So when you give a film for me to read and tell me whether this is adenoma or not, I request you to allow me to go to the console for me to put that little circle out there. This is called as an ROI, or the region of interest, or the cursor. So I put this, and the system is going to show me an automatic Hounsfield unit, or you will see it when you get the films. This is put up and you'll find over here a value of HU minus 10, HU minus 5, or HU 8. So these are characteristic features of fat in a lesion. And this is optimum. So if I have a density which is 10 and lesser, and especially on -2 or 0 or 2, I am very sure this is an adenoma. I don't even want a post-contrast scan, which means if you have some, very often during your imaging, we will ask for a direct post-contrast scan. So if that is done, and you feel, oops, I did not ask for an adrenal protocol and I'm seeing an adrenal nodule. Now, again, I will have to give contrast. Again, we will have to scan the patient. No, that's not the case. You just do a plain scan, do not give contrast again, and be prepared at the console. On the plain scan, is it a low Hounsfield unit? This is an adenoma. If it comes higher, and you're not sure, then you might have to repeat contrast again to come to the next part of it, which is not the anatomic, but the physiologic criteria that we are talking about. So on the non-enhanced, as I said, less than 10 HU suggests benign, and metastases have very little intracytoplasmic fat, so they will have a higher Hounsfield unit. Now, this is an adenoma in a patient with lung carcinoma. So as I said, it is important for us to not always look at the logic, but try to understand the morphology and anatomy of the findings. So do we need any further workup? No, because this is an enhanced scan. So this patient had already got an enhanced scan, and we saw this was 22 Hounsfield units, which is a borderline for enhancement. So we are not sure. So we go back, because these are routine patients. They don't always need a plain and a contrast. So you come back, do just a plain scan. This was -19 Hounsfield units. Patient doesn't need to do anything about it. Now, if it is more than 10, does it always mean it is malignant? No, it does not. So 30% of adenomas do not contain sufficient lipid to have a low attenuation on CT. So adrenal masses with more than 10 require a further workup. Okay, and that is a physiological part that we'll come up to. So both adenomas and metastasis show early arterial enhancement. So it doesn't help. So which is why when you only take an arterial phase, like you want to see a renal tumor, you want to see a hepatocellular carcinoma, you want a triphasic phase, which is arterial, venous, and washout, right? But that's not the case with adrenal because both of them show a rapid washing. So adenomas and mets cannot be differentiated. Okay, so you have to take a delayed phase by the time your contrast is washed out. So more the washout, it is going to be an adenoma. The percentage of washout of contrast is a useful parameter. Okay, two specific measurements are there: relative percent washout and a absolute percentage washout. So there are different formulae for that. And what we need to remember is that an absolute washout more than 60% is an adenoma, and a relative washout more than 40% also suggests an adenoma. So we usually take an absolute washout. We follow it as a protocol, and we see the enhanced Hounsfield unit. So the venous phase minus what we see at 15 minutes upon the enhanced minus the unenhanced, that is a plain scan, into 100%. So adenomas wash out faster, metastasis is going to retain contrast greater for a longer time. So you give contrast scan over 80 seconds, which is going to be a venous scan. You give, you again after 15 minutes do a washout scan, and that is a delayed scan. So if it has lit up, taken up contrast and has washed out, it is likely to be adenoma, more than 60%, I would say. And if it retains contrast, it is not likely to be an adenoma. So let us look at this. This is an absolute washout of 70% from this density here to this density here, and this is an adenoma. So when do you use an MRI in this algorithm? So it is for a problem solving modality. So as we said, there are very few which will not have macroscopic fat. So the next choice is to see what happens on an MRI. There is an optional sequence which I mentioned was gadolinium, that is post contrast, and the second is a chemical shift imaging. So if you are doing an MRI for an adenoma, so this sequence becomes mandatory, which is a CSI or the chemical shift imaging. What does it do? It relies on different resonance frequency rates of protons in fat and water molecules. So the whole concept of MRI is magnetic resonance imaging. So as and when there is turbulence created, there is certain kind of signal which is given off by the resonating protons. So every chemical or a molecule has a certain rate at which the protons are going to precess, or they are going to resonate or resonate. So fat will have a separate rate, water will have a separate rate. So in this sequence, it takes the consideration of the behavior of different molecules, and it shows the molecules in a different way. So this is the most sensitive method. So here you can differentiate fat and water. So let us see how. We have this technique for detecting lipid within an organ. So this is a cross-sectional imaging. This is the vertebral body. This is the left kidney and the right kidney, the IVC, the aorta, the diaphragmatic crust on the right and the left. And here is the adrenal gland. This is the stomach. This is the liver, gallbladder, bowel, okay, part of the pancreas. So coming here to the adrenal lesion, this is nicely iso-intense over here. Which sequence is this? This is more like a T1 base sequence. Now, what do we see? There is an in phase and an opposed phase. And there is something called as India ink artifact. So just imagine whatever you saw over here is now being demarcated. You take a black marker in your hand and start drawing a margin around everything. And this is the kind of a picture you get. This is because of the interface of the fat which is getting suppressed. So, you know, this is an opposed phase image and this is an in phase image. And in the opposed phase image, if the structure which has a lot of fat is going to suppress, becomes darker, so I know that this is fat. So this is a chemical shift imaging. How do you identify? What if you did not have this lesion Could you have identified? Yes, you would have. What you see is you will be given a pair of images, of which one image has more of these shades of gray in which you see the anatomy, and a paired image of the same section will have as if there are margins or markers drawn along the organs or defining or outlining the organs. This is your opposed face image. So if for any of your long case or short case, in case they show you an MR which has this, by and large, they will use it only for showing you an adrenal adenoma with suppression, or to highlight that this adrenal adenoma is not suppressing. It is very specific for the sequence. Okay, so as I think I've explained, just another example where you see this entire shade of gray structure, the adrenal gland, and you can appreciate the outlining and drawing all along over here as a margins. This is the opposed phase and it is nicely suppressing. So now you will tell me that this is an adenoma. Okay, yeah, now one thing is there is a loss, or how do you see how much is the signal loss expected? So we look at the signal of the spleen, this spleen signal intensity, and there are certain quantitative measurements that can be done based on the signal intensity in the adrenal lesion and with reference to the spleen, but we don't use them so routinely. They're more, we don't really resort to those because they're very objective and they may not help. Okay. So on the out of phase images, adenomas appear darker than the in phase images. Metastasis or carcinoma, because of lack of lipid, they appear bright on both in phase as well as opposed phase. So how do we by and large try to differentiate benign and malignant lesions? The size, okay, where these are usually less than 4 and these are more than 4. Temporal change over size, if they're increasing, you're worried about not being benign. Smooth margins versus irregular margins and shape and heterogeneous, these are homogeneous. Plain CT, there would be less than 10 Hounsfield units, these would be more. CCT we've discussed, and quick washout on the delayed phase versus prolonged washout on the delayed phase. Now, again, so I think this is covered, adenoma malignancy, differentiating again. This is an example of how a patient had undergone a PET CT also for staging, and there is brilliant or intense SUV uptake of an FDG PET, and this was an adenoma, a metastasis. When we cannot accurately diagnose on a CT or an MR or a PET, then adrenal biopsy should be considered to establish definitive diagnosis. So the indications would be for staging of a known malignancy, identifying an unknown primary malignancy, and differentiating benign from malignant adrenal mass in equivocal cases. So this is just an example of how it's a trans hepatic route over here to get an adrenal biopsy. There was no other plane possible. And here, this is a plane posteriorly, just parahepatic and right into the adrenal gland. Now, adenoma, so this is just a little theory about it. A common age is 20 to 29 years and 7% in those older than 70 years. Benign, generally with no malignant potential and mostly non-functional. And when not functional, you don't really need to intervene. I did describe its features, so I think I can skip that. But here is that adenoma nicely sitting out here. This is an example of showing the various phases. So I'm seeing a plane scan over here, which would be this phase. Look at the aorta. If the aorta is bright and the IVC is barely seen, then this has got to be an arterial phase. Mind you, very often there can be tricuspid regurgitation and you get intense enhancement in the aorta and the IVC. So how do you differentiate that? Because sometimes somebody can try tricking you on that. So if you see such a bright contrast in the aorta, this has to be an arterial phase. Okay, if it is a venous phase and your vein is also enhancing up, this is how a venous phase is. This is the shade of whiteness that you see in a venous phase. It could be a little more than this, and this is how you see it in the aorta and the IVC. This is a venous phase. But if you see bright contrast here and bright contrast here, then it's an aortic, it's an arterial phase with some tricuspid regurgitation. So you are still in an arterial phase. So everything that you will look at will then depend on keeping in mind that you're looking at an arterial phase. So these are the certain nuances when somebody can try tricking you. So there's nothing, I mean, I'm seeing this adrenal gland over here, and there's some scalloping around seen over here posteriorly. I'm not sure. And on the venous phase also, I'm seeing here, and is hardly putting up any contrast. And if I see the plain scan over here, this was definitely quite dark, and this is definitely an adenoma, though it is kind of taking up some contrast over here in the venous phase, but it is hardly, it's probably washed out. This enhancing nodule is not seen here. So even without having my parameters or knowing what HU it is, I can say that this is an adrenal adenoma. This is an MRI again. So recap, this is a nice soft tissue, and this is suppressing over here, and dark, this is an adenoma. So what is the algorithm you follow? Plain scan, less than 10 Hounsfield unit is benign. More than 10 Hounsfield unit, you have two options. Now what do? Either you do a delayed contrast CT, or you go here. So I would say you go to a delayed contrast CT at 10 minutes. If the washout, if it is washing off, it's benign. If it's not washing out, you may choose to do a biopsy, or you may choose to do a chemical shift MRI. If there is drop off signal, if it becomes black, it is benign. If it doesn't, you need to biopsy. So CT does not allow differentiation of functioning from non-functioning masses. The presence of contralateral adrenal atrophy suggests that a lesion may be functioning, because pituitary ACTH secretion is suppressed by the elevated cortisol level. So it is just a trick that we can use, but we cannot be sure. Now, ACCs, that is adrenocortical carcinomas, they have bimodal peaks first and fourth decade, often identified early in children because it tends to be hormonally active. Invasion of the IVC is quite a well-known complication of ACCs. Now, how do we identify them? Irregular shape, yes. Inhomogeneous, yes. More than 4 centimeters, unilateral, calcifications are seen. It has a high density, this is generally more than 20. Washout at 10 minutes would be there because these are intensely vascular. Absolute contrast washout would be less than 60%. Hypo-intense compared with liver, T1 and T2 on an MRI, and they have a high uptake on PET CT, and they usually would have local invasion adjoining, or they would have metastasis. So just on this plain scan, I can just incidentally see that there is some large structure over here which has a different gray than the adjoining parenchyma. So where there could have been a large metastatic lesion also, you would give contrast and see what happens at that site. Another example, intensely enhancing periphery necrotic center. This was also an ACC. Here there is a large lesion, relatively poor vascularity. We can see the intense arterial phase, and there are some calcifications also. On ultrasound, they can be seen very well there, because by the time the patient comes, they are large, more than 5 centimeters, lobulated irregular margins. They are heterogeneous. They will have calcification, and so they show throw shadowing. They may have an echogenic rim, internal hemorrhage, necrosis, and metastatic spread. So this is an example of where there is an adenoma, intensely enhancing, heterogeneous over here. Sorry, that was an adrenocortical carcinoma. Larger lesions which are more than 4 centimeters may appear heterogeneous due to central necrosis, and high density areas can be seen because of internal hemorrhage. Now coming to metastasis, that the fourth most common organ after lung, liver, and bone. Despite the high rate of metastasis to the adrenal glands, up to 70% of them will have malignancies, still they present with adrenal benign lesions as said. So again, they would have heterogeneous features. Now, looking at over here, bilateral presence of adrenal pathologies here. This patient was a known case of CA lung, and these are definitely metastatic lesions that they are not adenomas. There would be no other differential for these. On the ultrasound, atop the kidneys, and this would be the part of the spleen, and we do see the adrenal metastatic lesions seen very well over here. And this is on this is where the part of the liver is overshadowing, and we see the adrenal mets over here. Again, another patient of adrenal metastasis. So the pitfalls is lipid poor adenomas. So you use chemical shift MRI for differentiating. And another caveat is when you're dealing with metastasis from hepatocellular carcinoma and renal cell carcinoma, they will have a signal drop because they also are rich in lipid rich cells. And I'm sure you'll are much more well versed with renal tumors which have presence of lipid rich cells. So these are caveats where there can be an error in diagnosis. Also, liver and kidney tumors produce hypervascular metastasis that may show a very rapid washout, which is more than 60%. So when we are looking at vascular tumors of the liver, the kidney, the pancreas, or the thyroid, we better not to stick to the absolute threshold values that we discussed. Now, myelolipoma is uncommon. They have both mature fat and hematopoietic, like myelo and lipo components. Okay, they generally again have a very characteristic appearance, large amount of fat. They look echogenic here on this ultrasound. And on CT, there is a lot of suppression. They will have a lot of fat also. They have the density will be -50 to -150. Like we saw in adenomas, they usually are less than 10, and they could be -5 to 10 is what I would say. Myelolipomas have intense amount of fat present within them. And look at this normal adrenal here, and this you also see the normal adrenal here. It is stretched out by this exophytic mass that is seen. Again, intensely dark. This is a myelolipoma again. MRI, we see the fat very well. So we will see it high on T1, T2, and it suppresses on fat sat. So that's the hallmark of diagnosis. Lymphoma, this is an unusual site, but usually you would have bilateral involvement, and they may be lobulated or a nodular contour. So they're seen as solid homogeneous masses, soft tissue density, mild enhancement, and calcifications may be present, especially after radiation therapy. MRI is not very specific for these. Coming to hyperfunctioning adrenal masses. So pheochromocytomas, we all know the rule of 10 very well. Usually they are unilateral and they are benign. So clinical features are generally the telltale signs. You would rather come to the radiology department and tell me that I'm suspecting a pheo over here. What's your opinion? So that's how strong a clinician knows that this is likely to be a pheochromocytoma. There are associated syndromes. So what is my role here? So I have to localize a tumor which has already been diagnosed clinically or biochemically, and identify whether it is intraadrenal or whether it is unilateral, bilateral, and whether it is metastatic. So typically it's a solid intraadrenal mass, ranges in size from 1 to 20 centimeters. Ectopic pheochromocytomas or paragangliomas can occur anywhere in the neural, where the neural crest cells are present in the body. On ultrasound, it may be well marginated, iso to hypoechoic, may have necrosis and hemorrhage. CT, they are well-defined round masses, may have calcification, necrosis, or cystic change. And vascular lesions, they have intense enhancement uniformly after contrast administration, or there may be heterogeneous contrast, heterogeneous enhancement with necrotic areas. So this is hemorrhagic areas within, and so this is like quite, this is a delayed scan, I would say, not a plain scan, because I can see some contrast over here. But there is a lot of some hemorrhagic, some fat, and some necrotic areas seen within. Again, this is a large, well-defined mass. Again, lot of necrotic and cystic changes. This is also a pheochromocytoma. This was metastatic. There is intense peripheral enhancement and a lot of lung nodules, and the tumor, everything showing a good uptake on the PET CT scan. MIBG has a very good role in establishing and confirming the diagnosis, and especially for looking at extraadrenal pheochromocytoma sites and for residual diseases. This was again a single speck of calcification. This was a metastatic nodule of the pheochromocytoma. An MRI appearance, again, peripherally intensely enhancing with large centrally necrotic portions. Out of phase, there is no signal drop in these lesions. Can you identify over here? Yes. So, okay, so there was absolutely no signal drop. Adrenal cortical neoplasms like Cushing's syndrome. These can be ACTH dependent or independent. This is an example of adrenal cortical hyperplasia. So generally it is seen with Cushing's syndrome, and hyperplasia can be diffuse or nodular. So, so sometimes when a nodular contour is given, so we need to see whether it's the adrenal gland with one nodular contour, which is an adrenal nodule, or overall it has. So here there was, I mean, it was like a hyperplastic kind of a gland, and they're generally bilateral. Hemorrhage again, so this is a plain scan, I would say, because there's no contrast seen over here in the aorta. And this is the adrenal here, and this is the left adrenal and the left kidney. This is the right adrenal, and it is higher density. The density is higher than the aorta. It is iso to the liver, but still a little higher. This is going to be because of hemorrhage. Tuberculosis is known in our country, and we often see bilateral calcific histoplasmosis is another cause. But yes, we see histoplasmosis also. So generally, these are the two common causes of bilateral calcifications, with fairly maintaining the shape of the gland also. And this was a case of adrenal tuberculosis. So I would conclude here saying that adrenal masses are common incidental findings. We need to assess whether it is benign or malignant. We have to use the algorithm as discussed, and it should be used in conjunction with clinical judgment. And pheochromocytomas may often be picked up as incidental findings, and we need to have our clinical and biochemical workup there. Thank you so much.
I mean, thank you so much, Palak, for giving that talk. It was quite comprehensive, and I guess it will benefit a lot of the students who have logged in for this clinic. I think Dr. Gaurang Shah, anything?
Yeah, Palak, thank you very much, and it was very elaborative. And I'm sure that our students, they don't only listen this live presentation, but they go on YouTube and they again listen it, and they memorize it. So I think you've done an excellent job. Thank you very much. It will be very helpful to all our students. Okay, thank you. Good
Sure.
night.
Thank you so much for having me
And
here. Good
sometime
night.
we'll welcome you again in this forum. Thank you so much.
Thank
for
you very much.
participating.
Very good session.
Yeah, thank you so much. May I just request if I can log out?
Yeah, please. We'll
Thank
continue with it.
Yeah.
Thank you so
Thank
much.
you.
Good
Thank you
night.
so much. Good night.
Yeah. So, okay, we were discussing about the management.
Yeah.
Yeah, Ganesh, you can go ahead. You can ask them.
So, Ojas.
Yes, sir.
Management. I mean,
Sir,
ये last scan I think Achint ने दिखाया था. DOTA talk. The heterogeneous mass in the left suprarenal region does not show somatostatin receptor. Fine, that's okay. I think we discussed about this DOTA-TEC and FDG.
Yeah. Fine.
So in this particular case, I think both are not helping us so much, right?
yes, sir.
So how will you plan management, sir? Gite sir, कुछ बोलना चाहते?
नहीं sir.
Okay. So
Yes, sir. So based on
coming
the
to
biochemical,
management,
yes. So based on the biochemical evaluation and the imaging findings of this patient, it seems to be a non-functional tumor, more likely adenoma, more likely to be benign. However, the patient is symptomatic, having left flank pains in last 3 months. So I will discuss with the patient and the relatives regarding the nature of the disease, and accordingly explain him the chances that this might be a benign, or since the size is still more than 4 centimeter, for a region which is between 4 to 6 centimeter, chances of malignancy is around 9 to 12%. So I would also considering that we could opt for a surgery in which we remove the do a left side adenectomy, and accordingly plan the patient for a surgery, sir.
okay, that's quite okay. So surgery, any approach वगैरह कुछ, your choice?
So I would go for a open transperitoneal adenectomy, sir.
Okay, no problem. That will be what, chevron incision midline?
So you can take a left subcostal incision, or we could go for a chevron. So it's a midline, or we could go for a mainly some midline incision.
Okay, so I guess there could be a choice between left subcostal, which is extended a little bit on either side, or a midline.
Yes, sir.
Or, I mean, technically for adrenal sake, if you have seen laparoscopic, I guess it's okay to answer laparoscopic in an adrenal also, probably. Because it's
Yeah.
quite
Yes.
commonly done for adrenals.
Yes, sir.
And it does save a good bit of morbidity.
Yes, sir.
I mean, even the midline, you're going to take a fairly okay incision for this 4.5 centimeter. Or if you take a 11th rib bed, you are going to do a thoracoabdominal or at least, the flank.
Yes, sir.
So I guess flank incision is also okay for this. Matlab, we can, if we take 11th and if we try to push the pleura up, not open it, don't damage
Yeah.
the pleura, go ahead, dissect out the adrenal, take the. So when you generally do the steps, in this case, the anesthetists and the inductions and the pre-op of the patient with respect to adrenal will always be managed.
Yes, sir.
So intra-op, say, suppose if this is a FIO.
Yes, sir.
So what are the precautions generally, or how is the preparation also? Because I think that's the most common usual case in adrenal. I mean,
Yes, sir.
so how do you pre-op manage a FIO?
Yes, sir.
And how do you kind of take care intra-op?
Yes, sir. So preoperative management will first involve after the complete evaluation, and now we have diagnosed the case of pheochromocytoma. Patient will first start on alpha blockade. Either phenoxybenzamine would be started around 2 to 3 weeks before the planned surgery date, in which we start with around 10 milligram twice a day, and then increase every 2 to 3 days till around maximum dose would be around 1 milligram per kg. This will be given till the night of surgery, omitted on the day of surgery to prevent post-op hypotension. Along with alpha blockers, after 2 to 3 days, then we will start with beta blockers, either metoprolol or atenolol. In atenolol, 25 to 50 milligrams twice a day or 3 times a day would be started. Then we could also start the patient on mityrosine for the which inhibits the enzyme L-dopa synthase for decreasing the production of the catecholamines. And patient would be admitted around 1 or 2 days prior, in which we encourage the patient, we hydrate the patient well, give and a lot of fluid will be given. It started at a higher rate day before surgery. Also, salt loading should be started as an increased amount of salt intake around 2 to 3 weeks prior to the surgery, and increased amount of fluids.
So what is the logic in that?
After the surgery, when we remove the adrenal glands, there will be sudden decrease in the catecholamine levels, and because of that, there can be sudden hypotension. So we have to provide for the volume expansion.
So we technically try to increase the intravascular volume.
Intravascular volume, yes, sir.
But I mean, very honestly, many of these things have a bit changed. I mean, many of the endocrinologists now don't start with phenoxybenzamine actually.
Yes, sir.
They start with prazosin,
Okay,
as you mentioned.
Okay, yes, sir.
Yeah, prazosin. Then many still add something like amlodipine, and
Yes.
otherwise the beta blockers which you mentioned, and bring the BP down. I
Yes,
mean,
sir.
with the calculated dosage or increase in dose of each of these drugs.
Yes, sir.
And then the vascular volume is more or less today monitored and managed usually by the anesthetists, ideally.
Yes, sir.
They would certainly put an arterial line in such a patient and may or may not be a central line.
Yes, sir.
So what about the intra-op?
So I would like to mention the preoperative that there is a Rosen criteria for assessment of this blockade, which is no episode of blood pressure more than 160/90 in the 24 hours prior to the surgery. No ventricular premature beats, that is should be episode less than 5 per minute. No episode of orthostatic postural hypertension less than 85 by 40 millimeters mercury, and no ST-T wave changes.
Okay, so this is published in the year.
So 2017, sir, I think. So,
Okay, no
2017.
problem.
Yes, sir.
Okay.
Intraoperatively, first the anesthetist would be as involved as a team, as in the anesthetist will preload the patient with a good amount of volume before during the surgery and as part of the surgery. During the surgery, if doing laparoscopically or even open surgery, certain principles need to be followed. One is, if you're doing a laparoscopic, there should be no pulling of the tissue to avoid release of the catecholamines. Then before clamping the adrenal vein, the anesthetist should be informed so that they can preload the patient. And also the peritoneum over the adrenal gland should not be disturbed, as in to gentle handling of the tissue so as to prevent release of the catecholamines into the vascular system.
Okay. And which are the drugs kept by anesthetist if if the BP goes very high, like say 300?
Nitroprusside or labetalol, esmolol could be done. Yes.
And
So one more thing.
either of these three, they are given in infusions.
Yes, sir. Yes, sir.
Yeah. Tell me one more thing.
One more thing, sir. The anesthetist would avoid halothane and desflurane because they will increase the arrhythmogenic effects of the catecholamines. Also, they would be avoiding fentanyl, morphine, because these can also increase the catecholamine effect. Fentanyl,
Okay.
morphine should be avoided. Propofol, fentanyl, morphine should be avoided.
Okay. I think that completes it probably. So one last question. What do you think? Open surgery, laparoscopic again,
Ganesh,
which causes less handling?
Ganesh, there is
Yes, sir.
one, I think, Achin, are you ready with that small
Yes, sir. Yes,
case?
sir. Yes, sir.
So there is another case. Just we will show this CT scan and other things. Okay, and you can just
So
ask them.
because this discussion is anyway over.
Yeah.
So 23-year-old young male complains of flank pain. These are the reports.
Plasma metanephrine 57. Urine normal है नहीं सब.
Yeah, almost. Yeah,
Okay,
only
near,
metanephrine creatine ratio is marginally
yeah,
right.
that's okay. मतलब it's near normal. Yeah.
Yeah, normal.
These are the MRI films, sir. I have multiple images.
MRI. चला गया क्या? एड्रिनल को इधर दिख नहीं. हाँ.
It is a adrenal cyst.
Okay.
Just उसका report पढ़ो.
A thin-walled cystic lesion, altered T1 hypointensity and T2 hyperintensity signals seen in right suprarenal area measuring 6.2 into 5.8 centimeter. Cystic lesion causing mass effect on liver parenchyma. However, no evidence of enhancing neuron nodule separations. Benign adrenal cyst.
Okay.
Okay. Now show what else he has done.
This is CT report, sir. Thin-walled, non-separated cystic lesion noted in right adrenal area, 6 by 5.5. And this is a chest X-ray. This he has undergone DOTA PET scan.
Any report of that?
Yes. Well-defined, large, lobulated, non-enhancing, non-DOTA, knock-avid, hyperdense cystic lesion noted in right suprarenal fossa, measuring 6.2 into 4.8 centimeter.
But इसमें indicated है क्या DOTA?
No,
I mean,
patient himself has done it.
Okay, okay. Because otherwise, if there is no, I mean, hypertension, if the metanephrine serum, metanephrine are normal,
hypertension.
yeah,
He
then
has
we
got,
will not technically do it.
Yeah. So in this case, how to go about?
तो कौन ओजस और कौन दूसरा कौन है आंसर करना?
Abhishek Ghosh.
Yes, Abhishek.
Abhishek.
Yes, sir. Sir, since the history is indicative of hypertension and yes, sir, hypertension you mentioned. So, and then the urinary metanephrites are marginally raised. Sir, can I see the report just once? So, sir, then our evaluation will be more in the lines of pheochromocytoma, sir. Although on MRI it has come out to be a benign cyst, sir. We should proceed with the hormonal study to characterize the functionality of the lesion, sir.
Okay.
Yes, sir. So in that case, sir, we should proceed with the serum catecholamine levels and urinary fractionated catecholamine levels along with clonidine suppression tests, sir, to find out the central or the peripheral cause of the hormonal disturbance, sir. Yes, sir.
So Ganesh, in such cases,
Yes, sir.
it is advisable to again consider this as a FIO and start the preparation and then only take up the surgery.
I mean, sir, here to everything looks not like a few. So, but anesthetists usually take due care. I mean,
Okay.
if generally metanephrines and all are suggestive of not a few, then we are okay with it. Like we tell the anesthetist that it's okay. And in between, like some people, there are some POs sometimes who will have normal serum metanephrines and serum normetanephrines plasma. So we have seen that also. And then when we sometimes handle with laparoscopy also, which is like less handling in minimal invasive, even with that, sometimes there is a mild BP rise intra.
Yeah.
So I think with
Better
current
to just
understanding
remove
and
it.
everything, the anesthetists manage it very well.
Yeah. Okay. So again, in this case also, the answer is surgery, right?
A surgery because the tumor, I mean, the cyst is probably 6.5 centimeter in size, and
Right.
it is like aborting, whatever, and then there is a complaint of pain.
Right.
So that way we can matlab, otherwise these are the same operating criteria for a renal cyst also.
Okay. Fine. So you go ahead. You were asking him just the last question. Laparoscopy, robotic, and open.
Matlab, approach. So what would you say about the approaches and the handling?
So we can still go for this this 4 centimeter mass, the first one. So we can go ahead with laparoscopic also. It will have as in lesser morbidity and a shorter hospital stay and better post-op pain, less post-op pain. So we can go for a laparoscopic surgery as well. And in this case, also the CT is more like a history of benign pathology. So a laparoscopic surgery could be offered. Also, that the patient does not have a history of past surgeries, no any cardiovascular compromise. So laparoscopic surgery could be an option.
So I guess, I mean, in any kind of adrenal lesion, which is of a, say, minimally invasive or open, everything can be offered. Only thing is, when you are suspecting a diagnosis or when you are having a clinical diagnosis of adrenocortical cancer, you have to be very extra careful and not damage the tumor capsule of the ACC.
Yes.
That's for sure. The other things are like okay only. Because if the tumor breaks open and it's an adrenocortical cancer, it will seed somewhere in the abdomen because of the pneumoperitoneum. So
Yes.
that is the only thing. So you have to take due care. Otherwise, the whole surgeon's lobby is like you can do minimally invasive. Obviously, there is very less handling of few. And another thing is in minimal invasive approaches, you can maybe dissect the venous part and cut off the veins in between. Obviously, as you said, after telling the anesthetist before cutting well in advance so that they are well prepared with everything, including, as you said, loading the intravascular volume plus keeping those drugs ready, basically noradrenaline and very remotely vasopressin,
Yes.
which might be needed to push up the BP. Now, post-operative, only one single question before we end. So, how do we manage post-op? Suppose, say, I have shifted the patient on a noradrenaline to the recovery, surgical recovery. Okay, I'll ask a specific question. Chalo. Normally, we expect that the noradrenaline will go down in the subsequent period. So there are two questions. One is, usually when do you see the requirement of noradrenaline getting out? And when, or otherwise, when do you see the patient picking up with the normal BP?
We have made up for the loss of intravascular volume. So if there is any blood loss, we have made up for that. If in case of this, we have loaded with the intravascular volume, then the BP would come up again. And and then we measure for the central venous pressure and the urine output. Accordingly, we would assess whether.
So generally, if a patient is shifted on a noradrenaline drip, usually by next day, sometime the drip is tapered off. Usually, again with increasing the intravascular volume and SOS blood requirements. But if we are doing a minimal invasive surgery, the blood loss is very minimal. It's something like 50 ml or usually or 100 ml max. Nothing more than that, unless you are going to do open surgery and cut the ribs and have a blood loss. So that is it. Many times what we see is the BP remains a little low, and sometimes you have to give regular shots of hydrocortisone initially. So because of the high circulating catecholamines, the other adrenal gland is suppressed many times. So that is what point I was trying to elicit from you. So till the other adrenal gland or a little extra capacity, supplement with the hydrocortisone. So,
Sir, also hypoglycemia, sir, because of rebound hyperinsulinemia should be taken care of.
Sure. So, say you do a surgery, will you leave a drain or you will not leave a drain? Yes, Abhishek.
Yes, sir, we'll leave a drain, sir.
Okay, great. So generally in open surgery, we leave a drain only. Many times in lap surgery, you wait with the decreased pneumo pressure and check if something is really going to bleed or not. And I mean, there is a practice that you may not leave a drain in that problem. It's basically, again, this question is actually individual surgical safety followed by individual principles and protocols at institutes and individual surgeons. So we leave at that.
Yes.
So, sir, और कोई question? एक question है last. Suppose if you have to do a bilateral FIO, what are the options?
Partial cortical sparing adrenectomy. Is one
Okay,
option.
partial cortical sparing is acceptable. Partial matlab? Removing only one limb.
No, sir. Both sides.
So if you leave medulla on the other side, other limb, then there can be a FIO there also. Huh? So you do a cortex sparing. Cortex sparing is right answer. And then how will you, what are the drugs used to, substitute for the normal hormones?
So fludrocortisone.
Yeah.
And dexamethasone and hydrocortisone could be also used, but mainly fludrocortisone.
Generally, fludrocortisone in a long term will be used for mineralocorticoids and glucose. So, sir, or koi, I don't think if you both have any questions.
No. I think everything is covered, and we will have one more clinic with the for the FIO by Nalini. If we'll see how it goes. And we'll complete
Next time
everything.
or sometime.
Or sometime, I don't know. I'll have to
Nalini
talk
madam
to her.
को बोलना पड़ेगा, but then.
Yeah. So we'll have to talk to her, and then we'll go ahead. So let us see.
Okay.
But you have covered quite a lot of things. And,
very nicely covered.
And I think Dr. Palak's lecture was very, very comprehensive. So that covered the imaging in a very high way.
Not only imaging, even the part of the theory and so many. So if someone is listening to this clinic if they listen to it again 2 or 3 times, I think they will have a good revision. So I think we'll conclude here.
Yeah. Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir. Good night, sir.
Good night.
Good
Bye
night,
bye.
Ganesh
Thank you,
bhai.
Gaurang Shah,
Yeah,
sir.
yeah,
Thank you,
bye.
Bakshi, sir. Thank you.
Bye bye.
Thank you,
Good
sir.
night.
Good night, Gite, sir.
Thank you,
Good night,
Gite, sir.
Gite, sir.
Thank you, sir.
Bye. Well done, boys. Well done.
Thank you,
Good.
sir.
Thank you, sir.